2022 or January 22nd, 2026 meeting minutes. I'll ask for unanimous consent. There's no objections. Then the minutes are approved. I'll move on to new business. And our first speaker is Shelley Arthright with hospital readmissions.
Thank you. Good morning, everybody. So I'm so excited for this morning because we have a fabulous agenda. We've got a lot of guest speakers, and it's exciting to talk about hospital readmissions. And it's not something that you hear about when things are going well. Right? And we just cruise through and everyone's doing what they're supposed to do. But when hospital readmissions are not going well, it has a tremendous impact on community health. And just a few things. Readmission rates within 30 days signal very poor quality and significant harm. It drives up mortality risks, it worsens quality of life, and it puts a strain on local resources. And it leads to financial penalties for hospitals. So today we have a couple guest speakers, and we're going to talk about a way that our community works together between agencies to keep our hospital readmission rates low. We're thankful and excited for DRMC. They have a long-running stat. It is one of the, in Maryland, consistently remains the lowest and often best in the state for 30-day readmission rates, and they frequently fall below 6%. So that's an exciting thing, and like I said, we just really don't talk about it and don't celebrate these kinds of things when everything is going well. So recently they received an award, several different awards, and maybe someone from GRMC can talk about that when it's their turn. And then we did ask Cassie Collins today to come from our internal home health agency. And we're going to kick it off with her this morning to talk about the role of home health and how that affects readmission rates in the county and what that looks like. And she too needs an award. So that's very exciting.
You cannot see the speaker. Well, it's because she's presenting.
We did that this morning. Is that Rodney?
Yeah.
Landon set up the audio visual just a little bit differently so that we could see the participation in the room because we're hoping to have a great discussion.
We don't see that. We just see a page, Dare County Home Health. We see a picture of that.
You cannot see the room?
No, because she's sharing her.
Okay. Okay. Well,
No big deal, but
yeah. We're going to kick it over to her and she's going to start anyway. So I'll go grab IT and we can make sure we change that when we have our discussion. Thanks for letting us know, Rodney.
okay, thanks.
All right. Good morning. My name is Cassie Collins. I'm the director of Garrett County Home Health. Just a little background on me. I am a nurse. I've been with Garrett County Home Health since 2019. I started just as a field nurse and I quickly fell in love with it and then had the lucky opportunity to move up to director. So I prepared a slideshow, kind of just goes over services, some challenges we face, how to make referrals, that kind of thing, because I don't think a lot of people understand the background of us. Okay, about home health. Home health provides a skilled service in the comfort of a patient's home. Our services are PT, OT, nursing, and a home health aide. The purpose of home health is to assist patients in improving their quality of life, and we work closely with their primary care providers to create a plan of care that promotes their independence at home. Whether recovering from illness, surgery, or managing a chronic illness, our team brings personalized care right to the patient's doorstep in the county. We serve over 76 patients, and it's an average for us on a month. For the last 4 weeks, we've been well over 80 patients, which has been great. A lot of things people don't understand who qualifies for home health. We're public health, so we accept anybody on services. as an agency that's Medicare certified, we have to follow all Medicare guidelines, which makes things just a little bit tricky. Referrals are always reviewed either by myself or my nursing supervisor. We must have a physician's order that has a qualifying diagnosis for services. That's where things get a little tricky. And a diagnosis has to be an acute exacerbation or a change in their chronic condition. PDGM changed a lot of things, weakness, falls, that kind of stuff is no longer covered for home health services, which kind of creates one of the challenges that I'll talk about later. A patient must also be homebound. That's just simple as it's a taxing effort for them to get out of their home. They need a walker, a cane, assistance of a person to get out. Our goal as an agency is to improve from start of care to discharge. We want to get them back to their previous level of functioning prior to the exacerbation in their illness. Insurance eligibility, it goes over. We accept all insurances. It doesn't matter what insurance you have, or if you're uninsured, you can still have home health. We have sliding fee scales, all that kind of stuff. And I'll go over some of the challenges that insurance causes us. Referral process. So we can get a referral from a primary care, an acute facility, inpatient rehab, same-day surgery, nursing homes, all kinds of different entities, really. We can get some from, directly from an ortho facility, pain clinics, it doesn't matter. We receive an average of 83 referrals a month. Like I said, we accept and process all referrals. There are times when the referral source will cancel it because the patient goes to an inpatient rehab, or we have patients that sometimes decline services. Referrals must have a minimum of the top 4 items. So a patient demographic sheet, their insurance information. We have to have an order or face-to-face. Historically, there was a standard face-to-face form, but now as things are changing, a lot of facilities like Ruby and Garrett just have a standard order form that has all of the keywords that you need. A covered by diagnosis, it has to say intermittent nursing or skilled need. And then it has to show the services that they want in the home. And then there's a progress note or a visit note. But obviously other beneficial referral documentation is med list, discharge summary, any relevant labs, and therapy notes if they're applicable. That just helps my team provide better care whenever they're in the home. Once we receive a referral, we review it, accept it, process it. We're in the home within 48 hours. Referrals are, which I'll talk about this more later, referrals are sent via fax, email, or we use a referral source management type of company called CarePort, which has really helped streamline our referral processes because you have your larger entities that use that on the acute side to send post-acute, which is us. Services provided. Like I said, we provide skilled nursing, PT, OT, and a home health aid. Just some kind of, this is just goes over general examples of services. Some things that I like to tell people that they don't realize that we do. Nursing can do anything, chronic wound management. We do more than just med management and chronic disease management. IV antibiotics. We have a patient on services who has been on, I think since 2018. He gets an infusion every 8 weeks. We see him every 8 weeks and give him an infusion that's essential for his ulcerative colitis. So people don't realize that we can see patients as long as it's a skilled, necessary service. We can see them more long term. Physical therapy, they do more than just leg kicks and that kind of stuff. Dynamic balance, fall prevention. We do safety evaluations in the home. DME. We're working directly with Health Education and Outreach right now for a TBI grant. We're providing patients with essential DME in their home to prevent falls and TBIs. So that's been really great for us because DME is hard for patients because Medicare doesn't cover anything for a bathroom. So patients have to pay for that out of pocket. Occupational therapy, they do the more fine motor skills, upper body, but they can do a lot of different like cognitive things as well, like remembering to take their medications and that kind of stuff. Home health aid. She does your showering and bathing. She works underneath the discretion of an RN or an OT. And you can, misconception, you cannot have a home health aid unless you're working with occupational therapy. That's a Medicare guideline. Just because occupational therapy oversees that portion of the care. So the home health aid follows the occupational therapy plan of care. Why would you choose home health? So home health helps reduce hospital admissions, readmissions, because we provide clinical oversight in a home where we can identify warning signs and early intervention to prevent unnecessary admissions. It improves chronic disease management through skilled nursing therapy and monitoring in the home. Nurses and therapists, we assess vital signs and symptoms daily and overall stability on conditions such as heart failure, COPD, diabetes, and hypertension. It addresses health equity by reaching patients who face transportation issues, access barriers. Often we see patients who are unable to get out of their home to go to vital medical appointments. We often coordinate a bridge between the provider and the patient. It strengthens care transitions from hospital to community, which is critical under the total cost of care accountability. We're able to reinforce discharge instructions, provide disease management education, and confirm medication accuracy. We provide a real-world assessment in the patient's home environment. Home health is no longer just a post-acute care service. It is a strategic partner in population health management for patients, and it needs more coordinated, accessible, patient-centered care. A huge thing, patients thrive more in their home than they do in an inpatient facility. We just see them do a lot. They're glad to be home and they're glad to have our services at home. Challenges. There are many, but that's just healthcare in general. I'm sure that Mount Laurel faces these, Garrett faces these. So I'm just going to highlight a couple that I think are important. So higher chronic disease, such as diabetes, heart failure, COPD. Rural communities often see a higher incidence of chronic illness due to our social determinants. Older population and caregiving services. A lot of these patients that are 65 and up live alone. They don't have a caregiver, and they should have a caregiver because they're not really safe to be at home by themselves. So forming that bridge, but then you have the caregiver shortages in the community, and that causes a huge rift in care. Hesitation to accept outside help. We live in a very rural community. People are set in their ways. They don't really want someone coming in and bothering them. Unsafe living conditions, that kind of goes hand in hand with not wanting us to come in. A lot of patients live, and I didn't realize this until I became a home health nurse, because I worked med-surg, OR, and that kind of stuff beforehand. The poverty level in this county is huge, and patients don't want us to come in and see the holes in their floor, or they don't have running water, or they use a bucket, you know what I mean? Things like that. So we have a big, some patients will deny us just for solely not wanting us to come in their home. Staff burnout due to high caseloads and travel demands. Like I said, our census has been above 80 for the past 4 weeks. We are fully staffed, which I'm glad to say. And we manage a census of above 80 very well, but that doesn't mean that the burden's not there. Travel between 2 patients can be over an hour. We serve all of Garrett County. That's clear to the tip in PA, it's everywhere. So you get some outskirt patients that don't live right here in town, and so you got to plan travel around. Safety concerns due to road conditions. I have been on some really back roads just to get to a patient's home, and you would think to yourself, nobody lives back here. There's no way. So obviously we're in wintertime. That hinders us a lot trying to get to these patients' homes. Some of these big snowstorms, the nurses can't access the driveways, so it's more of telephone conversations. How are you doing? Making sure they're okay. Until obviously the patients can get plowed out and their driveways accessible. Health literacy barriers, huge in Garrett County as well. They don't understand their discharge instructions, their medical information, their medications are huge. And then obviously medical technology use in a home. Remote patient monitoring is something that we're working on for home health, and I think we'll see more challenges as far as the health literacy barriers and technology. Providers are unclear on our criteria for home health. Like I said, we follow all Medicare guidelines. That puts a lot of stipulations on things. Your normal run-of-the-mill diagnoses, falls, and that kind of stuff are not covered. And then on top of that, homebound status, providers, they write their notes in a certain way. And if there's little pieces in there that if we were to get an audit,
would look bad on us, so they shouldn't be on services. But we work very diligently with the providers to make sure we get everyone on services. I'm not going to say a lot on this, lack of shared EHR systems. That's just general statement. Fax dependent processes. So most of the referral sources locally still fax their referrals to us. 2 weeks ago, our fax system went down. I think for almost 3 days. So that's referrals not coming into us. So that's huge. And when I talked to Landon and Travis about our fax system being broken, I don't know which one of them said, they were like, why are people still faxing stuff to you? And I was like, because that's how we get the referrals. Like, I don't know, I don't know that process is changeable, but insurances are huge. We're out of network for, I think, almost every private insurance entity. What the insurance companies don't realize, we're the only game in Garrett County, the only home health agency. The patient doesn't go through us, they are not getting services. We tried to explain that. We're working on it, but it makes it really hard because if they're out of network, they're going to have a copay, which could be up to 50%, which is going to be close to over $100 a visit. So we see an increased denial of services because they can't afford to pay us, which is huge. Because they warrant the service, they just can't afford it. Home health honors, I'm sure everyone's seen the post, but we received the Home Health Care Consumer Assessment and Healthcare Provider and System Honors Program. We were recognized again this year for the 2nd year in a row. This is based on patient satisfaction surveys. This is when a patient satisfaction survey is sent on every home health patient. And you have to be above at least 85% in all evaluated questions. So we got this for the 2nd year in a row, which I think is great. It shows that my staff is doing an amazing job in the field, and that our patients truly adore us. And despite all of the challenges we have providing care in this county, they go out there and they do it with dignity and grace and compassion. And so I'm really, really happy we got it for the 2nd year in a row, and hopefully we continue to get it. I have a new action group on my Garrett County. It is now Home Health in Garrett County, and it is a public group. So I welcome you guys to go on, make an account and join. I'll be putting different measures in there as far as average census for the month, number of referrals, total number of visits for each discipline, different things like that. I plan on expanding more broader, but there is some good base information in there right now. And I think it'll be good for, for other community resources to go and see what's going on in home health. Patient testimonials. So these are long. They're longer, actually, the real ones are, but I couldn't really make them any smaller because both were really, really good. Like the first one I'm going to read, I'll just read it aloud for you. This is a patient who has been off and on our services since 2022. This is a statement from her daughter. And so she said, it all started in October 2022 when my mom had a fall in her home, leaving her in critical condition for months and in rehabilitation for another year. I would like to let you know what an amazing home health department you have here in Garrett County. I was told to think about what I would be taking on when I brought her home. Well, let me tell you, I could not have done it without my home health family. They've been a true blessing to us. Our caring nursing staff keeps track of her vitals, provides medications, offers medical supplies, answers questions, and gives honest advice. The therapist, PT, and OT helped my mom build strength so she could walk again with assistance. Their exercises are very important in everyday activities. They have been our rock to recovery so many times, and we are forever grateful. Their care gives my mom security in knowing she can do it, and she puts her trust in them and her best foot forward. I want you to know and that I tell everyone what a wonderful and amazing team you have, and I highly recommended you to everyone. My mom's amazing story would have been very different if not for home health. Then the second one is a patient who had an unexpected, very, very serious illness, and he's been on our services, I think going on 2 years now. And we closely manage him because he's a transplant patient. But he said, the only reason I'm even able to be home at recovery at Garrett County Health Department. Carol is my point person in my rehab and my recovery journey. Besides drawing weekly labs, monitoring vitals and medications and more, she's my first line of defense should any issue or question arise. Anything from dropping off an ostomy bag to me on a Sunday morning when I unexpectedly ran out to advising me to head to the ED based on a change in how I look or sound on a rough weekly home visit. I feel like I have a concierge home healthcare provider in my corner 24/7. She knows me and my history better than anyone else on my healthcare team. She and her team are my first call any issues arise. I'm extremely lucky to have an amazing support structure of family and friends, and Carol and home health are vital components. They are the tip of the spear in holding that entire structure. So those are just 2 patient testimonials. Thank you. That's the end. If you have any questions, I want to answer. Yes.
I'm curious about, is this primarily Medicare? When you talk about being out of the network, is it all insurances, Medicare?
No, Medicare is covered 100%, as is Medicaid and any Medicaid MCO. It's basically private insurances. We also see a lot of UHC, the Medicare Advantage plan, which has kind of gone more obsolete here after the first of the year, but we do still see a couple. We just had one the other day. That's a 45% copay for us. So the patient wanted to proceed with services, but then they add more fiery hoops. That insurance company makes the primary care provider go on the site and make the referral to us. We can't just accept it from the referral entity. Yeah, but Medicare, Medicaid, all covered 100%. It's just basically private insurances. Yeah, that we have an issue with. Yes.
What EHR system is used by your team?
We're using that Smart My Unity.
Okay, and is there any way, I mean, is there any way that can talk to our EHR system? Like, have you ever looked into that to see if they could talk to each other?
I haven't. It'd be great if they would.
Yeah,
because there'd be way less of a disconnect, I think, if there was a unified EMR or a way for us to communicate better. Because then, you guys could see our notes from what's going on with us, or, vice versa. Oftentimes, if we have a patient that we can't get a hold of, we'll call you guys and be like, hey, like, are they readmitted, or that kind of stuff. It's more kind of like chasing your tail because we're not all connected.
yeah. What was the name of that again?
NetSmart My Unity.
NetSmart.
Yeah.
And then the other thing, this is just kudos to you and your team, that like the transition and the coordination of care is just so invaluable for us, because obviously we can't be there on a weekly basis, even if we're doing home visits. And so we just had so many patients that would have ended up going back into the hospital for readmissions, or would have had a lot worse outcomes if not for the home health team being able to go in and do that piece of it.
Right.
So very much appreciated.
Well, I mean, we commend you guys. I mean, Mount Laurel is one of, like, if we do have an issue, you guys the nurses are quick to respond, we get orders quick, you know what I mean? Like, and that's huge. Because unfortunately it's not that easy with every provider, and it really, especially, you're going into a weekend and there's an issue on a Friday and we're trying to scramble around so they are not readmitted through the weekend. And I would love to streamline that a little more with every primary care, whether it be getting standard order sets on simple things like UTI or that kind of stuff. But yeah, your guys' response on this is huge when coordinating.
Some of that EHR could help with that even more too. So if we could figure out a way to get that might be able to help.
Yeah.
Just for the sake of the agenda and those of us, that are online, if you want to introduce yourself.
Oh, sorry.
And then just, I know you're on the agenda and last, but if you guys want to just talk a little bit more about that.
Actually, I don't believe I am on the agenda, but I think it's Garrett Regional, I believe. But
You are on there as well.
oh, okay. I might have got the big skirt one.
There's an updated agenda.
Yes.
Oh,
Than the one I sent out.
sounds good.
I
Okay.
updated it.
Yeah.
No problem. I'm Michelle Dixon. I'm the CEO at Mountain Laurel Medical Center.
And so you just touched on a couple challenges, right? And from your, you had a long list of challenges up there as you were presenting, Cassie. And so if you had to choose your top 3 that you really think that here at the Health Planning Council, we could dive into, we could talk a little bit more about, like, given the social supports and the other agencies that are with us, what would those top 3 be? And Michelle just talked about the one, the EHR system.
EHR is huge.
And so like maybe a step down from that. obviously that's the gold standard with our EHRs, if they could all communicate to close the referral system. But until we get there someday, what could providers do in Garrett County to maybe close the gap even further when it comes to patient care?
Yeah. So kind of like I said, you know, we work closely with all primary care providers, but there are times where, you know, our hands are tied because we're not getting a call back, or, you know, which everyone is busy. But I think if you're looking at hospital readmission rate alone, you know, aside from referral processes and that kind of stuff, just general patients who are on our services and we're trying to keep them home. It's a matter of, I walk into a home and they've had a 5-pound weight gain because they're in congestive heart failure. I'm calling a primary care to get, you know, an increase in Lasix or a one-time dose, or, you know, advice on what to do, because we as home health providers can't just do that on a whim. It's not our scope of practice. So just having that, you know, that quick turnaround of getting these orders, because we can't do anything in a home without an order. So, you know, Michelle's providers have to give me an order, whether it be verbal. It can be as simple as verbal, and I just put it in my EMR and it gets faxed to them to be signed. You know, one-time Lasix dose or draw BMP, or, you know, like UTIs are huge. It's a potentially avoidable hospital readmission, and it's huge. And, you know, hospitals get dinged on it. Obviously, we get dinged on it. And it's as simple as like patients having UTI symptoms. Obviously, in my head, I'm like, okay, we need to get a UA, send it out. But this is why I say standardized orders from primary cares. Because if I just had a standard order set on my plan of care that I put on every single home health patient, it saves my nurses from calling Garrett Medical Group, hey, patient's having UTI symptoms, can we get an order for a UA? Don't hear back for 24 hours. The patient's starting to go septic, they're in the ER. Because there's nothing we can do. So like that's huge, like standard order sets, and then it would save time where like, okay, patients having UTI symptoms, we have a standard order, get a UA, goes to the primary care orders that antibiotic. Saves an ER visit, if that makes sense. And like I said, it kind of makes our hands tied because we can't just put orders in on a whim. You know what I mean? Like it has to come from the physician. So those are big things.
Do you guys have access to Epic?
No.
Okay, so
No, we don't.
so I do, and I fought really hard to get that, and it was not easy. But
Yes. You know, Carol mentioned that to me a couple weeks ago.
yeah, so part of the reason that the CPAS program has, I feel like, expanded is because I don't call providers anymore. I look up my patient and I pull what I need. And then if we have like Cologuard, it's a little bit different, but I can order that through Exact Science Epic Care Link. So like I can put in orders.
Yeah.
So I don't know how that would work for you guys, but if you can get access to Epic, you could pull their provider notes instead of having to call, and then you might be able to get like an order set like that that you were just talking about. I don't really know how it works, but I think if you got access to that, it would really help you.
Oh, absolutely. Yeah. And like,
help me tenfold.
and I've always wanted like a standard order set on like different things. Like I said, like chronic disease management, symptoms. Okay, here's the order set for that, order set for this. It's been like a big like dream hope of mine. I just never knew, and maybe this is the place to facilitate it. You know what I mean? Now that Michelle's up in Mount Laurel, we work closely with you guys, something we can create. But yeah, even having access to Epic alone, so that if I have a patient going to GRMC, I can get those ER notes.
Yes, that's, and I've had to do that
because
before
they won't always send them to me. So you know, they come back home. We go out for resumption of care. We have no clue what happened.
Or they try to fax it. If they do fax it, it gets lost in the fax.
You call it a medical records. Hey, I need these docs, and then
it's like the entire
faxing again. Sometimes it comes, sometimes it doesn't. You never know. Yeah, it's so the continuity of care alone, especially with ER visits and that kind of stuff. Most oftentimes, I'll normally call Mount Laurel and be like, "Hey, do you have the ER notes? You know what I mean? Can you fax them down to me?"
And that was my biggest argument to get that access. I was like, I'm not going to have to call anymore. I'm trying to streamline this continuity of care. Just
absolutely, yeah.
So you guys should look into doing that.
Yeah.
Great.
So I'd just like to talk to you after this because Corey from Mount Laurel and I are on the Maryland Parity Coalition, which has a primary focus of mental health, behavioral health, substance use on becoming, you know, the laws being enforced to keep things going. And there's all kinds of laws about when consumers are so many miles away from an in-network provider, and they're often overlooked and not enforced. So I want to talk with you, and I want to help dig in that for you. Because that would be Maryland Insurance Administration, and maybe even the Attorney General's office through their health. They have a healthcare unit, a health education advocacy unit. So I just want to help because we may be able to bring some advocacy on behalf of the local consumers.
Yeah, absolutely. And we have, and we come across a lot of even behavioral health like type patients on home health that, we often aren't sure what sources, what to do with, what I mean? So yeah, that's excellent. Yeah. Having another resource. Go ahead.
Go ahead, Tom.
Oh, good morning. Cassie, I want to congratulate you on that presentation. Unfortunately, in the last 4 years, I've had to use the medical facilities quite a bit more. But placing myself in that situation, I've noticed a number of problems, many of which you have addressed in this situation. One of the things that came up to mind watching this is the fact that it might be helpful if we had a volunteer advocacy program where people, either in the family, friends, or in the community, would volunteer to work with people in the community who live alone or do not have an advocate. The reason I appreciate this a lot is I have a sister who has 40 years and as a med-surg supervisor at Anne Arundel and Annapolis, and she goes with me to every medical appointment I go to. I always think that I can remember everything, and I get finished, and then she starts to talk to the doctor about the 3 things I forgot, which are really important. So I see the need for an advocacy program, one, to go with someone, because a lot of people are afraid to tell the doctor, no, that's not what my problem is. Well, here's what I'm experiencing. They just remain silent, they listen to the doctor, and they do whatever. But the problem is when they're told something to do, they don't necessarily remember it or handle it appropriately. And an advocate can go in and talk about symptoms that they've seen, behaviors, and so forth, and give the doctor a better idea about what's going on. Just as an idea, I don't know how you would do this, but it would probably be an adjunct to what you're doing through the home health program. But I'm sure there are people out there who are willing to assume that responsibility. That's all I have.
Thank you. Yeah, I mean, that's an excellent idea. There are some, if you get into these larger apartment buildings in the area, and you will see more like you have one person who kind of like does the neighborly thing for kind of all of the, a couple people that are down and out in the apartment building, and then they become kind of a point person, emergency contact, no relation at all, but it's just someone that kind of helps them. And we see that a lot in this community, and we do utilize them. So a program like that would honestly be great.
Yeah, I think the importance of it comes in when somebody who lives alone and doesn't have a real support system themselves, and that's where it would be most beneficial in terms of the patient care, and also avoiding unnecessary medical appointments because everything was covered by the patient and their advocate, and it gets things done faster. Thank you.
Yeah, absolutely. Thank you.
Who would pay for that, Tom?
Well, as an advocacy program, the only part that I would see which would be significant in terms of cost would be training someone who does not have any experience with certain aspects of medical care, okay, and being able to spot certain things. Other than that, it'd be purely voluntary. The individual would be a neighbor, a relative, a friend, or something like that. But I'm not trying to increase the cost of care. I'm trying to make sure it's most effective for the patient.
Seems to me something reminiscent of Maryland Legal Aid.
Hopefully a little more effective than it was when I was practicing. I'm sorry.
Do we have anyone online or inside the building here from Garrett Regional?
Hi, this is Stacy Holler. I work in marketing at Garrett Regional.
Okay, thank you, Stacy.
Mhm.
The agenda says home health referral provider. I'm assuming provider issues or questions that Garrett Regional might have. Can you address anything?
I was not on the agenda, so I'm not sure who that would have been. I'm not sure who would be it definitely would not be me, unfortunately. I just work in marketing.
Thanks, Stacy.
Sorry.
No, you're fine.
You wanna-
I think Jeannie was supposed to swing in if she had time.
Okay, I was gonna say that would probably be a Jeannie Miller or Kendra Thayer question for sure.
Jeannie Miller was supposed to swing by just to speak on the behalf of Garrett as a referral provider to us. There are one of our largest referral providers. I did not write it down, but Jeannie wanted to know the number of referrals they have sent to us in 2025. Shelley probably can quickly get her email. And we work really closely with them on hospital readmission and follow up on patients that go into their facility, just because, you have certain places you have a rapport with and easier access to information. 244. Garrett sent us 244 referrals in the year of 2025. So that's huge. They're a huge entity to us. We work very closely with them. Jeannie and Kendra are on multiple of my boards. So I think Jeannie was just going to speak to the, what it does for what we do for them, I guess, on their end, which I can't really speak to, but I hope that we do a good job at decreasing hospital readmission rate. And like I said, we do a good job of, we work with their liaisons, and if we have a patient go in, we follow up on them, because sometimes people will just fall off the grid. I had to send an email just the other day. I had 2 patients go into Garrett at the end of January. Crickets. Don't know where they went. And just for continuity of care, I try to follow up on them, so I don't want anyone to fall through the cracks, because sometimes patients will go home and we don't get resumption of care docs, and then they're just home and they don't know where we went. So I'm trying to bridge that gap as well, because we see that happen a lot. Unless the patient or family member calls us and says, "Hey, we're home," we have no way of knowing unless the referral source sends us resumption of care information.
Cassie, could you talk a little bit about, in your action group, you have different types of referrals,
Mhm.
and we talked a little bit about joint replacement. And if you could just share with the group a little bit about what that looks like for home health and how you work with joint replacement patients, since that's one of your larger sources.
Yeah, total joints, total hips and total knees are 2 of the largest diagnosis categories that we see, other than your chronic illnesses. And they are something that becomes increasingly difficult to navigate and to make sure we get out there timely. Obviously it's 2026, we're doing same day surgeries now. They're doing these knees and they're just tossing them right back out the door. They're coming home. They still have a block. They're not in any pain. They're feeling great. And if we don't get out there in a timely manner, that joint's going to wear off. They're in excruciating pain. Then they're not getting up out of their chair. And then, the joint will seize up. So knowing timely a joint's coming out of a service onto home health is huge, which I just recently was able to bridge that gap with Garrett. They're letting me know at the beginning of the week their same day joints for the week, so I can prepare, because I have a census of 85 patients on services right now. That's 85 other patients that are being seen by every discipline. Plus, we get 60 plus referrals, other referrals a month. You know what I mean? Garrett's not our only referral source. Mountain Laurel's not our only referral source. So being able to plan ahead to schedule timely, because therapy is so vital for these total joints, and making sure I get therapy out there within 48 hours or less if I can. So that's huge. But then also, and I always tell my staff that a total joint takes precedence to some extent because it's important. But also making sure we're providing necessary care to other acute patients, plus the patients we already have on services. So it's a big balancing act, honestly. But joints are big. And we see a lot more. Historically, physical therapists couldn't do a start of care. And now you're seeing more and more just physical therapy only referrals, because now a physical therapist can go out without a nurse.
they can perform our start of care, which is honestly great because previously to that, I'd send a nurse out. They would only need therapy. So then the nurse would never go back out. But then if the nurse doesn't go back out, I can't bill that nurse visit. So it's a whole snowball of things. But like I said, a PT only start of care, you see them a lot more from primary care, send them, patient with just something, falls or whatever it may be. So they'll send a PT only. Large entities of ortho companies, so like Chesapeake Orthopedics, Bethesda Orthopedics, Mountain State Ortho in Morgantown, will not give me a nurse order. It's therapy only, which really makes the scheduling tight because we have PT evals on the other 25 admissions we're doing for the week. You know what I mean? So just scheduling gets tight with the staff that I have. But knowing ahead of time and like timely, initiation of care, we're slowly working through that process. But we have been timely initiation of care is huge. It affects our star rating. I've harped on it for the last 3 years, I think. And we're finally like getting to the point where we are, I would say we're out in the home within 48 hours. I think our last ITs report 87% of the time. It's rare that we're not. And if we're not, it's probably going into a weekend. We got dumped on a Friday. My weekend's already full. The nurses can only do so much on a weekend, so still have to push till Monday. But I've also drilled transparency into my staff's head. If there's an issue, like an insurance issue, like the patient needs to know that. Like, hey, we have your referral. We're working on it. You know what I mean? So they're not sitting at home like, well, the hospital told me that someone would be here tomorrow at 8 a.m. That's another big misconception. Inpatient facilities tell them that we will be there the next day at 8 a.m. So then when we call, once we process the room, we call, they're like, well, someone told me you'd be here. And I'm like, I understand that. So I will be sending either myself or my nurse supervisor over to Garrett's joint clinic. Lori Davis does a joint clinic on Tuesdays and Thursdays, twice a month.
Just for the group, can you explain what the joint clinic does?
Yes. So to get a total joint, a hip or a knee, I don't know if it's a WV medicine thing or if it was a more of a something that came down the pipe. You have to take this class. It tells you what to expect on getting a joint. So I thought that was a good point place for me to send one of my staff or myself over to kind of so that they know what to expect from us. So yes, you're going to get a total knee done, and then you're going to hear from us in this span of time. You know what I mean? But kind of decrease the expectation a little bit because patients are told a lot of false things on an inpatient setting. So it's another I'll say, gap that we need to find a bridge to because, but like I said, it's hard for me because I can only do what I can locally. I mean, you get larger facilities like Johns Hopkins, Allegheny Gen, Ruby and Mon in general, they're clearing Morgantown. I don't have a point person there like I do at Mount Laurel or over at Garrett. So the larger facilities, it's harder to bridge the gap. So I just try to work, within this county as much as I can, and then hopefully can spread it out farther.
Okay. There is one other thing about safety evaluations in the home. You spoke a little bit about that in partnership with community health education and outreach. And I do know Community Action has a grant. It's a program called Seniors at Home, and they're taking new applications. Basically, they help with small home upgrades like grab bars, handrails, ramps, and better lighting. So that's another resource for folks. And you could call Community Action for maybe to get involved with that program.
Yes, we do a lot of community action referrals just for general, whether it's caregiving services or, different things like that. So that's, a lot of patients, we had a whole patient who couldn't get out of their home because they didn't have a ramp. Simple things like that, like having someone make a ramp for someone. So that's huge. And the safety evaluations, like I said, a lot of patients live in really unsafe places and unsafe conditions, but it's a very fine line to where are they unsafe to the point where we need to take the next step and bring in APS, or is it one of those things where what, it's Garrett County, this man's 85 years old, he likes living in his hoarded house. You know what I mean? Can he get to simple things? I always tell my nurses, can they get out in the event of a fire? If they cannot, they are not safe to be at home. And then we need to go the next step. What are we doing? Are we calling APS? Are we calling the primary care? Are we, what are we doing to make it so they can get out? It's rare that we decline a patient truly for safety issues. We try to do our due diligence to make it safe for them, that they could get out in the event of a fire. So unless they're a true hazard to themselves or my staff, we go into some scary places and try to get them the resources they need, which is hard.
I do have some patient examples if you wanted to. We have some. So we, like I said, we have several patients. I'd be curious what our numbers are for referrals.
It's on my to-do list is to get them out.
I'm sure it's not as much as the hospital, but
yeah, I wanted to have it before today, but I just sent Michelle, and that's probably 10% of your patients that are on our services right now. What I sent Michelle.
Okay.
So yeah.
So I already talked a little bit about the coordination of the patients, but I think there's other situations that you don't realize that are really good quality of life outcomes for patients. So there was a 91-year-old patient that we had that did an initial PT eval. So you can mention that. And then when PT evaluated her, they realized she was having a lot of pain in her shoulder, crepitus, decreased range of motion. So the patient hadn't notified us of this, but they notified the staff of it. They reached out to us, and the provider was, they were like, hey, we would recommend a steroid injection to the shoulder. They did a steroid injection for the patient and got a lot of relief for that. So it's just, just a general quality of life type thing. A lot of it, you mentioned the knee replacement. So we had a male that was discharged from the hospital. Pain wasn't well controlled. Again, home health coordinated with us, and then we were able to change the patient's medication regimen to get some better control. There's a lot on PT, OT patients that receive the services, do really well in the services, and we have one patient that you guys have had back and forth intermittently, constantly, that she does really, really well. Services are stopped, and she then starts to gradually decline. It's a cycle.
Yeah.
And we
We call them our frequent flyers.
Yeah.
But we love them.
And
We love them. One of the patient testimonials is a frequent flyer of ours, and but people need that boost. You know what I mean? They get to a certain point, but at the age of 91 or whatever they are, they're gonna trail back down, and then we just boost them back up again.
Yeah, I think they remember, they remember the teaching that you've done when you did it, and then they start to do it. But when there's not something, they are constantly reminding them to do it.
Yeah. And if we don't have a family member or a caregiver to teach to kind of keep it up, we have patients say all the time, well, I'm not going to do this on my own. You know what I mean?
Yeah.
So we don't have someone that's there that can stay on them. And that kind of speaks to Tom's thing, someone we could educate that would kind of keep them going.
Yeah.
After we're gone.
Absolutely. And this patient particularly, and I don't know if you've ever heard this feedback, but I think it speaks a lot to the program, is that Dr. Farrell actually and I were just talking about this one, that she would likely be bed bound with stage 4 pressure ulcers. That's not for home health, and that he says that home health is the reason that she's still alive. So it speaks a lot to your services, and I think just we're lucky to have you guys here.
I'm glad. Welcome.
You're welcome.
So it sounds like we've already talked about Mountain Laurel's Medical Center's issues with home health and what's working. So great. So we're to the time in the agenda where we do in-house and online questions or anything you'd like to offer today. I'll start inside here.
So as far as agency updates, I do want to mention that today our Healthy Families program was invited to attend a roundtable on home visiting with the Office of the Second Lady. So they are in DC today meeting with her. They were recognized as the one program out of Maryland to represent home visiting in Maryland. Maria has taken herself and about 5 members of her staff, as well as one of our families, to attend this roundtable. I'm excited about that.
People from the library. AHEC?
So David Stewart, AHEC West. I just want a couple of things. AHEC has received some money so that we can help with medication assistance, prescription assistance. More to be announced around all of that and how to access it. UPMC funded this through money from Maryland Physicians Care. So we are putting all the pieces in place. We're starting with UPMC patients first, but we're going to be rolling it out to the rest of the community. That'll be under the Healthy Together umbrella. Lydia here is the program coordinator of our Health Insurance Connector program is now going to extend all the way to Carroll County. We've been awarded the West region. Haven't been told how much money they're going to give us to do that. It's a tripling of our population that we serve, so it's a challenge there. I'm just trying to think of what other types of, we are rolling out soon, very, very soon, a link that people can use that's called AHEC West Connect /help. And it's going to lead people to, and it's meant for members of the community. We're going to be throwing this all around Georges Creek area because of all the things going on there after the floods. But people will be able to request help for themselves or someone else on a range of services, right? And at the same time, we have services on there where we don't have them built into the well-check system yet, but all of those requests go to community health workers at AHEC, and then they will be managed from there. Some will be direct referrals to our partners like Mount Laurel, the health department, social services, and then some the community health workers are just going to work those requests over the phones. So like people at libraries, librarians, ministers, anybody who wants to use this to help the people they see, it's going to be rolling out really soon, but it's the web address right now. It says coming soon, but it's ahecwestconnect.org/help. So just more to be revealed, more to be shown and explained.
Just a jumping off point there. Our unit is a recipient of Healthy Together, and at the 360 Access Hub, we have funds from Healthy Together and Care First, and we do food distributions. We have events there. It's a model based on recipes. You guys have heard about it before. This month, we're going to be there on March 18th from 1 to 6 p.m. And then we are going to be holding hours there on Fridays, starting March 20th, our staff. So, and it's a similar format. It is, you can go to the 360accesshub.com/help. Anyone can use the form to refer, and people can get enrolled and make sure that they have a consistent way to get food if they're food insecure. We partner with DSS, with anyone who wants to come and partner with us. We would love to have you. And of course, we always want to give a shout out to our volunteers who really help manage the day and pack boxes and do all sorts of things, greet guests, shop with them. So, and remember, when you use the referral form, if you're an agency, go ahead and put your name in the agency in that slot, because we do track those referrals and appreciate everyone who's participating.
I actually do have something. So I've been doing some research, putting together a talk for educational stuff about the benefits of reading and the how and why of reading to kids. It's about educational growing up, that sort of thing. But as part of that, I came across a bunch of stuff about the health and therapeutic benefits of reading to seniors, adults, and people in recovery. And so that's something that I potentially would to explore with other folks if that's something that appeals to anybody.
Brad? You have anything else from Mountain Laurel?
Our we are moving our Grantsville practice. So just to update everybody on that, we are looking at our first day in our new location being March 9th. Got postponed. Postponed a couple of times, but we are really targeting March 9th right now. So really excited for that. And our Grantsville pharmacy is up and running and it's done really well for the community, being that it's the the only pharmacy right in the community now. It's been very busy, so we're happy to see that.
County Commissioners? How about anyone online
Hirschberger Lane, which was the health department building.
have a report or a comment they'd like to share? Don't see any hands up, so I guess we'll move to adjourning the meeting today. Our next meeting is March 26th. So put that on your calendar. Thank you all for attending.